Thank you so much for that introduction. I too would like to acknowledge the lands on which we're gathered today, the lands of the Coast Salish peoples, and specifically the First Nations of the Musqueam, Squamish, and Tsleil-Waututh. And as always, we give gratitude for allowing us to live and work and play on these lands today. So in terms of my disclosures, I'm a proponent of paying attention and make profits on 2 books that I've written on the topic of paying attention. So that's it in terms of disclosure. I have no affiliations with pharma or any other industry. Before we jump into the topic today, how many of you in this room regularly practice mindfulness in your lives? And unfortunately, I can't see the folks online. So in the room, hands up if you do. Oh, a handful of people. Great. How many of you have heard of mindfulness and its applications to health topics? Okay, about half, just over half the room. Great. So hopefully by the end of this talk, not only will you know a little bit more about mindfulness and the evidence supporting it, but you might be intrigued to begin a mindfulness practice in your own lives, which would be a real win for me. You can leave with that. So just a little bit about some of the gynecologic cancers and the literature showing how the diagnosis and how the treatments can impact different aspects of sexual health. And you can see on the slide here a summary of many, many dozens of studies that have been done looking at the impact of various gynecologic cancers on sexual health. Admittedly, we have much more data on the impacts of cervical cancer and endometrial cancer than others, very, very little on vulvar. But across the board, the data indicate that a very high number of survivors of these cancers do experience sexual distress. And what do we mean by sexual distress? This is bother or interference secondary to a sexual symptom. So common sexual symptoms may be pain with sexual activity, loss of desire, difficulties reaching orgasm, fear of sexual activity, and so on. And for the clinicians in the room, I'm certain that you have encountered these symptoms as you care for these survivors. So why should we care about survivors' sexual health? And this may seem like a little bit of a cheeky question, but it's an important one because sometimes survivors themselves face that question of, well, should I be grateful that I'm alive? I've survived my cancer. Is this petty to focus on my sexual health and sexual symptoms? What the data indicate is that when there are sexual symptoms secondary to cancer, that it can impact many other facets of a person's life, quality of life, health, future health, relationships, mood, and so on. So it's not that these sexual symptoms stay isolated in a vacuum. They can have pretty profound effects on a person's more global quality of life. And so it's important that we pay attention to them. So how are we doing? This was data taken from a survey that was sent to almost 2,000 members of the Society of Gynecologic Oncology over the course of about 3 months. And it essentially asked these healthcare providers, do you ask about sexual health? Do you offer treatment? Have you received training in this area? And less than a quarter said that they had received sexual health training. And again, pair that with the numbers that I just showed you on the previous slide, which show that the vast majority of the patients that these providers see do experience these symptoms. That said, a high number of them were consulted by patients about sexual health. In other words, the vast majority had patients express some degree of sexual health issue. The majority, 64%, said they provided information to everyone about sexual health to varying degrees, some more in depth than others. And the study found that the more years out from training was associated with more of a negative view. Sex is private and discussing it will interfere. Maybe that's surprising to you, or maybe it's not. Maybe this is also a side effect of a little bit more training in medical school and residency and fellowship focused on sexual health. So it could be an artifact of that. Specifically, younger doctors were twice as likely to support patients choosing treatments based on sexual side effects. That's really interesting. If there's time, we can talk about this. And I'm really glad that Dr. Kwan is here today because we were both co-investigators on a trial for early stage cervical cancer that actually compared two different surgical treatments and found some differences with regards to sexual health. I'm not going to be presenting that, but if anyone wants to talk about that, I think that study was absolutely fascinating. When we think about how cancer might impact sexual health, you can see these different slices of time. So we know at pre-cancer treatment, we talk about sort of baseline sexual function. So this is after cancer diagnosis, but pre-cancer treatment, it's really important to have conversations with patients about what are their expectations about their post-treatment sexual function and provide education on what we know. And as I mentioned, there's a fair bit of data where we can say to patients, based on your cancer type and the kind of treatment that you're going to have, there's a moderate likelihood that you'll have some sexual symptoms. What can we do now to best equip you for those changes later on? And some patients will say, don't want to think about it now. Let me get through treatment, check back in 6 months. And other patients will want to perhaps influence their treatment plan based on expected sexual side effects. During treatment, of course, as there's an increase, even a spike in anxiety and depressive symptoms, continuing to have the conversation about sexual health is actually really important. For a lot of patients who are in advanced stages of their cancer, there's been some literature on this, that among ovarian cancer patients during treatment, that they will often say that sex or sexual activity is an opportunity for them to still feel alive, to still feel like they have some quality of life amidst a very, very difficult prognosis in their treatment outcome. And then at post-treatment, that's where we often see a whole new host of psychological symptoms arise. Fear of recurrence. Will the cancer come back? Can I transmit cancer to my partner? Will sex make cancer recur, etc.? And so again, another period of time that can contribute to changes in sexual health. And then sort of separate from cancer, there's the person's lifetime. There's, what are all of the things in their early development that may have predisposed them to sexual difficulties later on? Did they grow up in a home where they were told or taught that masturbation was a sin and that self-touch and self-pleasure was, a very bad thing to do. And as a result, they carried with them shame and secrecy throughout their entire life. Then, of course, there's precipitating factors. What maybe it was the cancer or the cancer treatment that precipitated the sexual symptoms. And then for survivors years out, there may be other factors that are contributing to ongoing sexual symptoms that may have little to do with cancer and its treatment. So we sort of take this lifetime trajectory in mind when we work with survivors who have sexual side effects. Of course, there are cultural aspects. We know that depending on a person's finances, ability, geography, cultural background, religious background, these might all impact their awareness of sexual symptoms, their ability to get help and pay for sexual health treatment, etc. And a lot of that can also impact cultural myths about sexual health and cancer. Among the first studies that I did with cervical cancer and sexual health, which was in Seattle, and I'll talk about that in a little bit more detail. But it was quite eye-opening for me to talk to the young group of survivors who felt that, both their cervical cancer and their sexual side effects were deserved in some way because of their choice to engage in sexual activity before marriage. And there was definitely an influence of culture and religion within that. Here on the slide is a snippet of some of what I've heard over the years, and some of this is captured in Anne Katz's excellent book on sex and cancer, that gives you a bit of a taste of what might some of the thoughts or irrational thoughts, if you will, be in the context of sex and cancer. Cancer is infectious and may be passed on from one to another. I've heard this from probably about 30 or 40 survivors over the year. So an extreme, I mean, first of all, this is an irrational fear. This is not true. But for the person who has this belief, it can directly impact not only their anxiety, but their willingness to engage in sexual activity with a partner. I cannot get married or find a partner after gynecologic cancer surgery. So in some ways, a bit of a death sentence for them. Only married women want to be sexually active. By the way, all of these are myths. Let's just make no mistake about it. All of these are complete myths. The breast is associated with fertility. That was a bit more relevant to kind of breast cancer. And alterations in body with surgery is associated with loss of feminine power and loss of ability to attract a partner. So these might be some of the unspoken things that patients and survivors might be holding on to that can directly impact their sexual health. So I'm going to move now and talk about a couple of studies, and obviously, given the title of my talk, we're going to spend the bulk of our time on mindfulness because really want to share with you some of the work that's been done there. But first, I'll share with you a study that I was involved with that was led out of Princess Margaret Cancer Center in Toronto. It was led by Catherine Clausen, who's a psychosocial cancer care provider, so a psychologist with expertise in survivorship. And what she developed was an online chat room, if you will. This was done about 8 years ago, before we've seen the explosion of online treatments and apps, et cetera, et cetera. So this was, at the time, a little bit cutting edge, and it was mostly patient-directed. So survivors of gynecologic cancer could log on to this chat group. It was moderated by a facilitator who had expertise both in sexual health as well as psychosocial oncology. And the question was really, can this kind of online asynchronous format be a place where survivors can have their questions about sexual dysfunction met, and can they seek support in that? So it was a supportive, expressive group versus a waitlist control. And you can see the number of different sites that were involved in the study. So I mentioned it was professionally moderated. They got some really good psychoeducation on a chat board window. And then they had 2 guest lectures by Dr. Sarah Ferguson, who's a gynecologic oncologist in Toronto. That was really the only synchronous time in in the intervention where survivors had real-time interaction with a healthcare provider. That's what it looked like. They logged into this and they could, there was a forum where they could leave some feedback, but really the bulk of the intervention was this chat room, and they could have an alias. They didn't have to have their own name. And what we found was that in comparison to the wait list was that sexual functioning improved. And so this wasn't really a treatment. This was, again, just a space for survivors to come together to support one another, have some questions addressed, and normalize the discussion. And at 4 months after the intervention, there was significant improvements in sexual distress and body image. So the paper is not published yet. It's under review at the moment. But I think for me, what it gives evidence for is you don't have to see, someone like me, specialist who specializes in sex therapy, encouraging survivors to come together, encouraging support groups where they can normalize one another, where they don't feel so broken and alone, while supplementing it with some evidence-based information can be pretty effective for survivors. Okay, so a little bit about mindfulness now. What do we mean by mindfulness? So yes, it is about paying attention. And that's probably half of what mindfulness is. It's about focusing the attention, present-centered awareness. But the other half of mindfulness is about how do we do that? And we do it non-judgment. That means as we're focusing on something, we're not judging ourselves for saying, oh, my attention is terrible. I'm a chronic multitasker. I hate yoga. I've never been able to sit on a pillow. All of that we sort of let be. And we return to the present moment in a non-judgmental, passionate way. So what are we paying attention to during mindfulness? Every thought, every feeling, and every bodily sensation just as it is. So as you're sitting here, you might pay attention right now to the feeling of your feet on the floor. And you can actually try that right now by closing your eyes. And for those of you who are logged in online, just focus your attention on the sensations between your feet and the floor. So what do you feel? Do you feel a soft? Do you feel hard ground? Do you feel the spaces between your toes? Do you feel tension in your foot? Do you feel tight shoes? Do you feel fuzzy socks? What are the sensations of those fuzzy socks? And as you're noticing that, you're just observing sensations. You're not judging yourself for wearing tight shoes. You're not scrutinizing yourself for the hole in the sock. You're just observing, just as it is. So essentially, this is mindfulness. This is a snapshot of some of the main studies that my lab has done over the years, and you can see a number of studies with cancer survivors. My introduction to this was when I was a psychology resident and then a fellow at the University of Washington in Seattle. And at the time, I was doing research with gynecologic cancer survivors, mostly cervical cancer survivors. And as was mentioned in the intro, I have a real interest in sexual psychophysiology. So what actually happens in the body during sexual response. So we have ways of measuring that. If anyone wants to see, you can come up for a field trip to the 6th floor and see the lab and how we measure physiological sexual arousal. And at the same time as doing research with these survivors, clinically, I was receiving training on a treatment called dialectical behavior therapy, which is the leading treatment for borderline personality disorder. And for those of you who don't know much about borderline personality disorder, it's a psychological condition, personality, that is associated with a lot of extreme ups and downs in mood. So a person over the course of an hour can escalate from feeling on top of the world to feeling completely empty and detached, to being deeply in love with the people in their life, to feeling like no one cares about them. And these rapid swings in mood are incredibly distressing for the person with borderline personality. And they tend to resort to really maladaptive coping mechanisms, things like cutting. And for the person with borderline, they will say that the kind of physiological relief that happens with cutting is the only way that they can cope with these moods. Now, for the vast majority of us in the room, that might feel completely, oh goodness, how does that work exactly? But for the person who experiences this, it is very real. And so dialectical behavior therapy is the leading evidence-based treatment. And one component of DBT is mindfulness training. And so as I was learning the therapy over the 2 years when I was there, what I learned was that tuning into difficult sensations can be far more effective than distracting from them, than tuning out, than trying to turn them off. And it turns out for DBT that mindfulness is the core mechanism by which that behavior therapy works to help reduce cutting and other maladaptive treatments. So that's all background. Okay, how does this relate to gynae cancer survivors? Well, I sort of had this moment of being fully immersed in this clinical treatment that I was learning, doing research with gynecologic cancer survivors who were saying to me, I have a profound sense of loss. I no longer know my body. I can feel my hand or my partner's hand on my vulva, and there is no pleasurable sensation associated with it whatsoever. I don't know who I am anymore, et cetera, et cetera. And it just struck me that mindfulness might be useful for this group. So what did we do? I immersed myself in learning and practicing mindfulness. I started going to groups and reading everything I could. By the way, highly recommend The Miracle of Mindfulness by Thich Nhat Hanh, who passed away last year, Master Zen Buddhist, who wrote probably the first book that was the most accessible introduction of mindfulness into kind of Western healthcare. And as I was learning and being immersed in mindfulness, I pulled together a small group of gynae cancer survivors, about 20 of them, and I said, would you be willing to learn this with me? I kind of don't know what I'm doing. And, you know, you tried other things. This might be a tool that we can learn together and apply. So that's what we did. And it was only 3 sessions spaced over 3 months. So a session a month and then lots of homework in between. And what we did in terms of measuring it is, so this upper left-hand corner is BPA's vaginal pulse amplitude. It's basically the physiological sexual response when we bring them into the lab. And you can see that there was, you know, the effect size was small, but also the sample size was pretty small. This was really a proof of concept study. But whether it was their physiological response or their perceptions of their arousal, or their mental arousal in their mind, you can see that there was an inkling of evidence that maybe mindfulness could be useful for this group. Then I came to UBC and we replicated this study in a larger group versus a control group and essentially found the same thing. We included other measures of sexual response. And still using that 3-session format, we found that this group of survivors self-reported improvements in sexual response, significantly more than the control group. So fast forward several years and lots of different pilot studies, we finally got money from CIHR to run a randomized clinical trial. This was not in cancer survivors. This was in a general sample of women with low desire. They were all cisgendered women, although we really tried hard to recruit gender diverse persons assigned female at birth. And I'll try and make that distinction when it is relevant to the different studies that I'm talking about. Has anyone in here ever ran a psychological RCT before? Mm-hmm. They're really hard to do because what's your control group? As soon as you talk about sexual health or bring people together and fill out questionnaires about sexual health, again, because the topic we talk so little about, suddenly it becomes therapeutic. So it's not true. It's not a randomized controlled trial. Our main intervention was our 8-session mindfulness intervention. Yes, we departed from 3 and went to 8-session, mostly, well, exclusively based on participant feedback. They wanted more. But our comparison group was the same education that we delivered in the mindfulness group minus the mindfulness. So a little bit of psychoeducation about the sexual response cycle, prevalence of sexual concerns, etc. And we had about 150 women who were diagnosed with sexual desire disorder, sexual interest arousal disorder. And you can get a bit of a sense from the consort diagram what they did over time. We followed them for a year. So what did we do in the mindfulness group? So these were group sessions that we ran here on the 6th floor. And every session started with an in-depth guided meditation that one of us led. Whether the focus was on eating or noticing body sensations, we did some mindful stretching, you can see on the screen there. And after a few weeks of having the participants really establish a regular mindfulness program, we then began to move these skills into the sexual scenario. So as they looked at themselves in the mirror, as they explored their genitals, as they engaged in self-touch, as they engaged in sexual touching with a partner, etc., we integrated their developing mindfulness skills into these progressively sexual scenarios. One of the mindfulness exercises that we developed that turned out to be really important to the participants was something we call sexual sensations awareness. And what we asked our participants to do was to use a sexual tool. Any idea what a sexual tool is? Guesses? Yep, you guessed it. A vibrator or fantasy or erotica, something that reliably elicits the sexual response. And we asked them to engage with the tool for a few minutes, again, to reliably elicit some arousal, and then stop, and we paired it with a mindfulness exercise. And we actually have a separate publication where we evaluated this alone in comparison to some imagery and found that it significantly improved sexual arousal, self-reported as well as physiological. So that was one of the exercises we did. The comparison group, as you see here, there was no mindfulness, there was no cognitive behavioral therapy. It was mostly just education. So what did we find? Well, we found that engagement was pretty high. So MBCT is the mindfulness arm, STEP is the comparison education arm. You can see the number of people that attended at least 6 of the 8 sessions. So very high engagement, and also a lot of adherence to the homework exercise. So after every session, they would go home and fill out the homework, and then we would talk about the homework in the next session. In terms of some of the outcomes, so on the left is the education arm, on the right is the mindfulness arm. Significant, these are, you can see for those of you who want to see effect sizes, these are Cohen-D's that I have in the bottom right. Very large effect sizes for a psychological treatment, and much higher than all the pharmaceutical trials that have evaluated pharmacological treatments for low desire in women. And the improvements in distress were retained a year later. So the orange bars is 1 year later. In terms of desire, also a significant improvement, but you might notice here there's no interaction. So the education group had the same degree of improvement in desire as the mindfulness arm. And this is really important for, generalist healthcare providers to know. Giving basic education and information about sexual response is therapeutic. We have strong evidence that. I'll quickly zip through these. They had improved relationship satisfaction, and they ruminated less as well. So some pretty good evidence in a well-powered RCT that 8 sessions of mindfulness can significantly improve many domains of sexual response, and that improvements were retained a year later. So I'm going to share the findings from a second randomized trial on pain. And the reason why I'm showing you this is because eventually when we talk about gynecologic cancer survivors, pain with sex, vulvovaginal pain of any sort is a very common symptom, almost regardless of the kind of treatment that they've had. So we just talked about low desire. Now we're talking about a second very common symptom among gynecologic cancer survivors, which is genital pain. You might be wondering, how can tuning into pain help pain? That seems so paradoxical. If you pay attention to pain, doesn't that make it worse? The evidence says no. That there's a wealth of evidence looking at mindfulness as a treatment for chronic pains, and very, very strong evidence that it not only reduces distress associated with chronic pain, but it can reduce pain intensity itself. So with that, got a bit of money from CIHR. We did 2 pilot studies, got some effect sizes, and then applied to CIHR. And here we call it the COMFORT study, which is cognitive behavioral therapy, which is an evidence-based treatment for vulvar vaginal pain in women, and we compared it to our 8-session mindfulness intervention. So CBT, has anyone heard of CBT before? Yeah. Basically what you're doing is you're challenging thoughts. Remember that slide I showed you with all the irrational thoughts? You're targeting those thoughts, you're challenging them as a way to improve mood and change behavior. So the unit of kind of intervention is at thoughts, because those we can intervene. It's much harder to change behavior and emotions. And we had a treatment manual that was well established from my colleague Sophie Bergeron in Montreal. And we compared that to our mindfulness intervention for pain. So this is an adapted version to the treatment manual that I showed you before, because we had some specific mindfulness exercises for pain. What we did is we had women go home and elicit their vaginal pain, either with a finger or a Q-tip or a vaginal insert. And then they listened to a mindfulness recording while they related to those pain sensations in a different way. 130 women diagnosed with provoked vestibulodynia, which essentially is a chronic vulvar pain condition. There's a whole clinic up on the 6th floor called the UBC Center for Vulvar Health that specializes in the treatment of these patients. what do we find? So CBT on the left and mindfulness on the right. And we actually designed this as a non-inferiority study, which means that we were hoping that mindfulness would be as good as CBT for reducing pain. And what did we find? It was as good, and in fact, it was better. So you can see a year out, pain symptoms went down from 6.5 down to 3.5, and that reduction in pain was sustained. This finding has directly impacted care delivered in the vulvodynia program here and in many other vulvodynia programs around the world that now integrate mindfulness-based treatments alongside care by a gynecologist and a pelvic floor physiotherapist. So again, evidence that mindfulness can reduce pain and distress, and that those benefits can be retained a year later. So we're going to bring these two studies together now. And it's a study that we actually just published in the last couple of weeks that was focused on breast cancer survivors, not gynecologic cancer survivors, but the kinds of sexual symptoms that our breast cancer survivors tell us are fairly similar to the kinds of symptoms that our gynecologic cancer survivors tell us. So what we did is we integrated the findings and integrated those treatment manuals. We folded in a lot of education about cancer and how cancer treatments, as well as cancer diagnosis, might impact sexual health, and then delivered that alongside the mindfulness exercises in one arm, or the sex education, supportive sex education in the other arm. Our first group for this was scheduled to take place on March 20th, 2020. We had 12 breast cancer survivors that had the address to this building ready to go. And we had to call them the day before and say, we're switching to online. We have no idea. I've never even heard of Zoom before. We have no idea how we're going to do this. So we used FaceTime for our first group, FaceTime to deliver therapy. And then by session 2, we moved to Zoom. So the study over the next 2 years was exclusively done online, which actually turned out to be a wonderful thing because we could recruit survivors from all corners of the province, which was fantastic. So what we had about 118 breast cancer survivors. All of them had some degree of vulvovaginal pain and low desire, and they were randomized to one of these two treatments. Here's just a little bit about what you can see in terms of their demographics. And we're currently analyzing, what are some of the predictors? Does whether they had chemotherapy or not predict how well they did? Did the kind of radiation therapy impact how they did? Did whether they were on an ongoing aromatase inhibitor or not impact how they did? So these are some of the analyses that we're undergoing right now. We just published the main outcomes study just very, very recently. Again, compliance was very high. Of course, they were in their own home, so they didn't have to leave their home. And you can see compliance with homework was also really quite high. So what did we find? I'm just going to share a couple of the outcomes with you. Looking at sexual desire specifically, and we found that both groups had a significant improvement that was sustained at the 6-month follow-up. So again, evidence that giving good psychoeducation alone in breast cancer survivors can significantly improve their desire. And the distress findings, similarly, both education and mindfulness can significantly reduce sexual distress. You can see the effect sizes there as well. What about pain? So here we mailed each of them a little vaginal insert that was about the size of their pointer finger. And they did this at baseline, and then they did this again at post-treatment at 6 months. And their self-reports of pain, you can see that there was also an improvement in both groups with their pain over time. Pretty much all of the outcomes we see that the education group did, as well as the mindfulness group. So they ruminated less, they were more mindful. Interoceptive awareness is kind of ability to sense what's happening in the body. It was like when I asked you to pay attention to your foot. For those of you in the room who are highly interoceptively aware, you could feel your middle toe. You could feel the nail on your middle toe versus those of you who are less interoceptively aware. Are there toes there? I can't feel anything. So this is one of the mechanisms by which mindfulness works, is it really trains people to be much more attuned to those sensations in the body. So although the effect sizes were were smaller in this study of breast cancer survivors than in our 2 previous studies of non-cancer survivors, still a relatively simple and easy is not the right word, a relatively low investment intervention, relatively affordable, people can do in their home, can meaningfully improve sexual symptoms. So what are the implications of this? I'm fascinated by mechanisms and as well as moderators. So who are the patients that we should be recommending this to? It's not for everybody. We're doing a bit of work right now looking at neurodivergent people, because there's been some kind of clinical observation that maybe neurodivergent people have negative reactions to mindfulness, and there's no literature on that. So we're exploring that right now. So what are the predictors of, when patients in front of you, who would you recommend this to? And we need to do a bit more research there. And then also mechanisms. What are some of those underlying mechanisms by which mindfulness works? So although we haven't done this big 8-session treatment in an RCT for gynecologic cancer survivors, we feel that it probably would be very, very relevant based on all of our pilot work. One of the challenges with sex therapy and even delivering a mindfulness intervention is that it's not accessible to everybody, right? So psychologists are fee for service. We tend not to be, employed by big healthcare centers, et cetera. And so for people that don't have extended benefits or don't have the means to pay for a specialist, it might mean that they don't have access to these evidence-based treatments. So the last couple of slides I'll show you is something we've been working on quite a bit over the last about 6 years, and that is development of an app that we call eSense. So lots of barriers that people face when it comes to treatment for sexual health. We worked with a group of patients to develop eSense, which is web enabled. It's not an app yet. We're appifying it at the moment, but it's a mobile friendly a digital health tool that delivers in one arm 8 modules of mindfulness, the exact same mindfulness that we tested in our intervention, and in the other arm 8 modules of CBT. We hired a patient partner to do all the graphic illustrations, and we had another group of patient partners develop all of the case stories that are folded over the course of the 8 modules of eSense. So in the early days, we did 3 feasibility usability studies. Then we got some money to do an RCT, and then I'll end with telling you some of the fun stuff we're working on right now. Here's just a few of the illustrations. We attempted to have illustrations showing patients of different ages, of different sexual orientations, of different races, different body sizes, etc. We had animated GIFs, we had embedded videos, we had downloadable meditation files, whiteboard animations. It was definitely a labor of love to pull this together, but we're really, really happy with the final product. As you can see there, ooh, that didn't work. So after the RCT, we did an implementation science study where we partnered with 14 clinics across Canada and the US. And these were clinics that were administering either sexual medicine care by physicians or sex therapy by psychologists. And we asked them if they would be willing to let those patients who were sitting on a wait list for at least a month know about eSense. And so we weren't measuring efficacy in this implementation science study. We were looking at what clinics did this, what patients took it up, what barriers and facilitators got in the way, and how did it work in the real world. And so, yeah, here's some of the things that we're measuring, because this will help us understand when we export this out of the research environment, what's the real world need for a tool like this. Some of what we're doing right now is we have 3 different studies where we're adapting eSense to different populations. eSense Cancer, Dr. Kwanzaa, co-investigator on this one, and we worked with a group of gynecologic cancer survivors who worked through eSense as it is, and then told us how to modify it for gynecologic cancer survivors. And we're just about to start our feasibility study on that. And then we have an adaptation for gender diverse people. And then we're working on an adaptation for those patients who have vulvovaginal pain. So last slide. Sexual health can be cultivated after gynecologic cancer. And that's probably the most important sentence of this whole talk. That as you know gynecologic cancer survivors, as you work with them, as you're doing research that leads to better treatments for gynecologic cancer survivors, is that yes, sexual health can be impaired. It's often impaired with treatment, and it can be cultivated with evidence-based treatment. And part of that is acknowledging that sexual health is a core component of vitality. And then hopefully what this talk has highlighted to you is that mindfulness is simple, but not easy. It's a simple treatment because it's a simple intervention because all you're doing is paying attention, non-judgment. It's not easy because you're paying attention, non-judgment. And the nature of our mind to be everywhere except the present moment makes practicing mindfulness really hard. But it does work, and it's pretty accessible. So there's my coordinates if anyone wants to reach me. By the way, for any of the trainees that are in the room, I never thought I would write a book. I don't see myself as an author at all. But I also realized about a decade into doing this work that, a handful of people were reading my peer-reviewed publications, mostly my students. And so a publisher reached out to me and said, you should get your findings out to the popular media. And I said, okay, I'll go on a podcast, and ended up writing the book on the left. And it became quite a popular book. And people approached me saying, all right, you've convinced me that mindfulness can work. How do you do it now? So that gave rise to the second book, which is really walks the reader through all of the steps. So thank you for your attention. I'm happy to take any questions.